of Emcure Pharmaceuticals Limited welcome you all in next this series of no thrombosis. Today we have gathered with three more interesting cases and to have more discussion. So it gives me an immense pleasure to welcome our course director, Dr. M.S. Hiremat sir. We all know sir is a director at Cat Lab Ruby Hall Clinic Pune. Sir has been a former president of CSI and also a program chair of CSI conference in 2016. Sir has been a convener for the National Interventional Council of India of CSI from 2004 to 2006. Sir has delivered many live angioplasty courses to many national and international intervention conferences. Sir had proctored many interventional cardiologists and given live courses across the globe. Sir has a great experience in peripheral angioplasty, including leg, carotid, and iliacs. Sir has also participated in a groundbreaking trials. Thank you very much, sir, being a part of this session. Now, I also welcome our moderator, Dr. Jabir Abdul Kutti, sir. Sir is Senior Consultant and Director of Clinical Research at Lycée Hospital, Cochin. Sir is also in charge for Heart Failure Clinic and DNB Training Program. Sir has also been working as an editorial board member of Indian Heart Journal, Honorary Secretary of Society of Heart Failure and Transplantation, and Secretary to the Cardiovascular Research Society. Sir has a special interest in heart failure, ACS, intercardiac imaging, imaging and physiology, and anticoagulant and antiplatelet therapy. Now I also welcome our course moderator, Dr. A. Srinivas Kumar sir. Sir is currently working as a Director of Cardiology and Clinical Research at Apollo Hospital, India, Apollo, the Health City. Also Professor of Medicine at Apollo, IMSR, Jubilee Hills, Hyderabad. Sir is also Chairman of a FACT Foundations and Founder Director of TCT India South Asia Conference. Sir has a special interest in TAVI, intracoronary imaging, and also sir has been a past president of APCSI and past chairman of CSI NIC. Thank you very much, sir, being a part of this program. Now I also welcome our guest moderator, Dr. Prashant Advani, who is a consultant, preventive and clinical cardiologist and director of Advani Heart Line and Metabolic Center at Raipur. He is also working as an honorary visiting consultant in various corporate hospitals in Raipur and published many review articles and research papers in many national and international journals. Welcome our first speaker, Dr. Mainak Mukhopadhyay. He is a senior resident at Department of Cardiology of Minapur Medical College and Hospital, and also working as a visiting consultant international cardiologist at MRI Hospital, Salt Lake, and North City Hospital, Kolkata. He will be presenting on coronary artery perforation complication management. Now I welcome our second faculty for the day, Dr. Sanjay Bhatt. So he is a consultant interventional cardiologist at Aster DM Healthcare Limited, Bangalore, and he will be presenting a case of calcified LAT CTO. With this short introduction, I would like to hand over this session to our course director, Dr. M.S. Hiremat sir. Sir will be presenting a short case today, and then we will followed by the other faculty for today.
Sir, Dr. Mainak has joined and he wants to give the case first because he is, I think he has to go ahead.
So is it okay, sir? Dr.
Yeah.
Present? Okay.
Yeah, let him
you can share your slides.
Am I audible, sir?
Yes, yes.
Okay.
We can see.
Are my slides visible?
No, I think you need to unshare and share because we can see your folder, but not the slides. Please unshare and again share. Now you can share the presentation.
How can you see?
It's
Yes.
loading. Yes, just make a full mode.
Is it okay? Dr. Swami, please unmute.
Yeah, it's absolutely okay.
Okay. So, good evening, everybody. My respect to Dr. Hiremat sir, and I am grateful to Emcure for providing this opportunity to present my case over here. This was a case of complication that happened during the last year of my residency in DM. I did my DM from NRS Medical College, Kolkata. Regarding this case, there is no conflict of interest and informed consent of the patient taken regarding the presentation. Here I present my case. He was a 70 years old non-diabetic, non-hypertensive male smoker with recent unstable angina. The vitals were stable with normal CVS examination, ECG showing T inversion in one areal and V3 to V6. In echocardiography, there was no regional wall motion abnormality at rest with normal left ventricular ejection fraction. His TROP-T was negative. Other blood parameters were normal. Patient underwent CAG, revealing double vessel coronary artery disease with LAD proximal to mid-segment disease and RCA proximal focal stenosis. His angiography was done at some other institute and patient came to us. I have some beta shots also. This was the LAD. Can you see the video? Can you see the videos?
Yes.
Okay.
They are not moving. Yes, now we see contrast in RCA.
Okay. So what we did subsequently was that the PTCA was planned and informed consent obtained. Regarding the LAD lesion, we used EBU 3.5 6-French guide cap run through floppy guide wire. 2 by 15 millimeter semi-compliant balloon dilatation was done at 12 atmosphere of pressure. Then subsequently, the available stent was Metaphor as per government supplied at that point. Metaphor 3.5 into 44 millimeter days deployed uneventfully. Regarding the RCA lesion, we used JR guide 6 French run through floppy guide wire. 215 semi-compliant balloon dilation at 12 atmosphere. Then again, Metaphor 3.5 by 19 millimeter days deployed at 11 atmosphere. Just to remind that the RBP was around 14, whereas the nominal pressure was 9. And then subsequently, the nightmare started. Now, let me show the LED. This is the LED pre-dilatation. After that initial dilatation, LED stent deployment, LED post-stent deployment, then subsequent post-dilatation was done, and this was the LED final shot. Good flow and good TIMI score. Now, regarding the RCA stenting, the nightmare was that the post-stent deployment shot in RCA shows into cardiac component, then subsequent CPR, pedicardiocentesis, autologous transfusion, TPM, another catheter, engagement, rewiring, and balloon tamponade, everything was done. Protamine injection was done for heparin reversal. Unfortunately, at that point, we had the available cover stent size was something around 2.8. And hence, considering the chance of effectivity, because we already applied 0.5 and the higher risk of thrombosis later, it was avoided. Now, here, the entire story of the RCA. This is the RCA wiring. I'm showing again because there was no apparent visible calcification in the angiographic views. Then the balloon dilatation.
Kuta.
Post balloon dilatation RCA.
नहीं एक तेरा मीटिंग में है तो डॉक्टर राहुल ने फोन किया
The bed preparation was not adequate, I admit. Then the RCA stent positioning 3.5 into 19 millimeter.
ये तुम्हें डॉक्टर राहुल ने फोन किया
RCA stent deployment. Then just after the RCA stent deployment, the nightmare started, because here we can appreciate very significant amount of perforation. Although we didn't go up in very high pressure, neither there was any apparent visible significant calcification. Obviously we had no choice for any intracoronary imaging. So, but at least in angiographic view, there was no significant calcium. Unfortunately, everything came out considering the patient acute situation. So again, we re-engaged the catheter, TPM was done, balloon occlusion done. We rechecked sometimes, and there was again ongoing bleeding. So again, re-occlusion. Again, ongoing bleeding, re-occlusion. Then pericardiocentesis done. Everything was done within a very short duration. We have having so many clips, but everything happened in a very short duration. So pericardiocentesis done. Pictal catheter in situ within the pericardial cavity. Now we took a second catheter. And finally, the bleeding was controlled. Now, why I presented this case, because we are not very sure the exact reason for the perforation, because there was no apparent calcification in the coronary angiography, but still we are lacking the intracoronary imaging, so we can't be very sure. Even a small chunk of calcium can lead to this kind of perforation. And we suspect another possibility is any strain start fracture and causing this kind of perforation. So my take-home message for this case was that the no lesion is simple, because the LAD was much significant, and we thought that the RCA will be relatively cakewalk. So complication is a part of intervention, and we must have adequate homework and hardware support and CTVS backup to tackle them. Intervention is a team game, and keeping the nerve pool is a mantra. Calcium may be apparently invisible in fluoroscopy, but we should also keep the stent fracture possibility in mind, and there should be liberty to take help of the intracoronary imaging. Better braid preparation prior to implantation is essential, and checking the result. Now, two important point is to check the result keeping the balloon within the catheter after the post dilation, because even if there is a significant perforation, we can re-occlude immediately. And in perforation, we should never recheck with the snugly fit catheter, because it can lead to more severe kind of perforation. And balloon occlusion of the feeder vessel is an effective method to seal the perforation. So, thank you very much.
Thank you, Dr. Mainak. That was something which we have all gone through. I think as you age or your hair turns gray, you probably don't get this kind of problems. Before I give it to you, Dr. Srinivas Kumar, the balloon diameter on both was 3.5, right? Stent diameter.
Yes, sir. 3.5.
And the RCA perforation happened at what kind of pressure?
Just after the stent deployment, sir.
12.
At 11 atmosphere.
At 12 atmosphere. I mean, you said that balloon should be in the guide catheter. Take a picture, make sure there is no perforation, and then you take out the balloon catheter. I would go one step further. I would say that you deflate the balloon, just inject about 1 cc or half cc contrast, so that the balloon is still there. You don't have to spend another 20 seconds to get the balloon down the stent. So that would save even. So I would probably feel that anyway, we give nitro so many times. So whatever contrast is there in the guide catheter, if you give nitro, it will visualize the vessel. And if there is a perforation, which it can be seen. Also, the balloon that you took as an occluder balloon was probably a short length. No, it was probably 8 or 10 length. And you have to be very precise. Generally, the perforation may not be a millimeter perforation. It could be a line perforation. And I would probably feel that a 15 millimeter balloon, or you can definitely take a balloon which is size of the length of the stent, that can be taken, and that is the way to properly occlude. And the reverse with you reverse the heparin.
Yes, sir. We use protamine.
I know, but is there any timing? Like within 45 minutes, it's useful, and beyond 45 minutes, it's not useful.
Okay, sir.
Unless you want to add on this protamine timing?
Yeah, generally, if you have deployed the stent and you're worried about it clotting, generally, if the time is also over, you avoid reversal. But suppose it happened, you're not worried too much about stent getting blocked and the time is very fresh, then probably you could give it. But when you
I would feel, if you're late,
yeah, you need not.
like if it is beyond 45 minutes, the reversal action is very weak.
Yeah.
So it's the early part, say 20 minutes after your heparin, the protamine will work. But beyond that, I think it would probably be not useful. What do you think was the cause of perforation, Srinivas?
Actually, unfortunately, I couldn't see all the pictures clearly, so it was getting hanged up. That's why I'm not at loss not to comment. I couldn't see because it was all jerky. Maybe my internet problem here, I don't know. I couldn't see the images clearly. But it looked like optimally sized only. It didn't look like it is stretched the vessel too much. No, I don't know. Maybe calcium spicule, something was there which caused the trouble. I couldn't see it clearly. But it looked like it was not too much oversized. And the pressure also, he says, is gone up to only level atmospheres.
So do you suggest that when we do bed preparation, should we always image it from inside, so that you can pick up these areas of calcium? Not that your decision to do an angioplasty is going to change, you're already halfway through it. But if you do an imaging and if you find calcium, you'll probably be a little bit more control in your approach. Like the NC post-dilatation balloon probably would be a quarter size smaller, and then you can go to whatever pressures like 25 and 30, and not the equal size 3.5. I will not take in that case if there is a lot of calcium. Everything has its good and bad. Like a quarter size small balloon will not be able to push the stent into the vessel wall, especially if it is calcified. But Dr. Srinivas, what do you think if these kind of cases are imaged before? Are we likely to reduce the percentage of perforations?
Yeah, definitely. I think we can size the vessel. You can also image the morphology of the plaque. And as you said, you can prepare accordingly the bed and then take a decision. So it will be better. And one important point which Sir mentioned is don't take too short a balloon. Sometimes we may lead to multiple inflations. Again, that will cause more trouble. Take a longer balloon for occlusion. That is immediately I think important. Imaging facility was not there with you, or is it there? Maybe it was not. Many places they don't have. That is the problem. Other thing is, sir, sometimes some of the company makes, if the balloons, initially it used to happen, the crimping problem of the stent, and the balloons had one or two very minute, smaller holes in it. When inflated, even with the normal pressure, that jet which comes out of the balloon would used to go and hit the artery wall and produce intramural hematomas and very rarely perforations too. So that is a make problem of the stent and the balloon. And the balloon,
that is a balloon specially made for perforation. Let's put it that way.
Many times, sir, Indian companies, especially when they're crimping it too hard, one of the few struts I've seen gone into the balloons and damaged the balloons. And when you inflate it, that very thin streak which comes out, it comes with very high pressure and damages the arteries. So that is another mechanism where sometimes we could see, because 11 atmospheres I'm at loss to see why it has caused perforation unless there is calcific
You
spicule.
think when we inflate the balloon, Dr. Srinivas, should we go up to 6 and then from 6 onwards go slow? So that if the balloon is giving way at any particular point, you'll be able to probably see it early and not go higher pressure than say 8 or 10.
Yeah. But generally, we tend to go up to nominal pressure, no, sir. Go slowly, but nominal pressure of the stent was
no. I'm just saying go to nominal, which could be 10 in most of the stents.
Yeah, yeah.
But up to 6, go quickly so that the stent does not slip forward or backward.
Yeah.
And beyond 6 to 10,
Slowly.
I think go slow, so that, we are never prepared for perforation, actually, to be honest. And that's why we want to just go up, quickly finish and come out, Anything else that you would have done differently once you found the perforation? It was a big perforation. So a pigtail was placed in the pericardial space. Dr. Mainak, you can also tell us, looking back, would you have done something differently to avoid perforation? And once the perforation happened, how to deal with the perforation?
Sir, after the initial balloon dilatation, the bed preparation was suboptimal. If I look back now, after at least 2 to 3 years after doing the DM, then at present, what I feel that the bed preparation was suboptimal. And whenever the bed preparation is suboptimal, even after balloon dilation, we should think that there is very chance of some calcium, which may not be even visible on general angiography. Probably in that case, the game of the intracoronary imaging comes into play.
So Dr. Mainak is saying that the bed preparation is crucial. Is that correct? The stent should be always deployed at regular pressures, not very high pressure. So stent should not be used to stretch the atheroma. So atheroma should be stretched with balloon, bed should be prepared properly, and stent should just land there and get expanded to the fullest. Now that fullest is a big question. Some stent go at 6, some stent go at 14. So I would probably feel that deploy at about 8 or so, the stent balloon, and then bring in a NC balloon, which is short, and then you go high. That is our standard policy. Dr. Srinivas, same with you, or you do something?
Yeah, same, sir. But unless you are oversized with the size, sir, it is very unusual to have perforation at 11 itself, 11 atmospheric pressure. Did you notice that?
No. If it is written...
That's true. That is true.
It will happen at any pressure,
Yeah, but I think there should be something with the make of the stent and balloon also here. The 11 atmospheres producing, it didn't look so much calcium also. It is what I could see in the angiogram. It didn't look like it was too much calcium or indentation. Nothing of that sort was there. So there is something also to be with some other things also. But we can't be definite.
Any other ways in which, suppose perforation happens, if the pressures are stable, I had one perforation which actually the vessel perforated into the left ventricle. So it didn't perforate in the pericardium, but it perforated in the left ventricle. And when we took pictures, you could see the LV showing brisk contraction. So we were shocked. In fact, so far, this is the only time I have had one perforation right in the ventricle, and patients are absolutely stable. We didn't know whether to send him for surgery for that perforation. But we waited, and we took pictures after 3 or 4 days, and we didn't see continuation of the perforation. So in a way, we were lucky. But when perforation happens in the pericardium, the effect is immediate. When perforation happens like this into the ventricle, you may not realize it for a long time, and then sometimes it persists.
Sir,
where is Dr. Jabir? Is he there? Or?
Dr. Jabir sir is not there, but our other guest moderator Prashant Advani, Dr. Prashant Advani.
Prashant, you want to make a quick comment on whatever we have seen, all of us have seen so far?
Dr. Advani, are you there? He has joined, but I don't know what's...
Anyway, we can go for next presentation at 8:30.
Yeah.
All right.
So,
Next presentation, please.
sir, this is from your side only because we have Dr.
Okay. All right. So I'm going to be showing you one lady who just walked into the evening outpatient. Basically, she had come with a husband who had an angioplasty about 3 years back. And we did a stress test for him. And he said, I also want to do a stress test. She was 69, diabetic for about 10 years. She was only 40 kilos. So weight-wise, she was quite small. And her stress test was positive in first minute. And ECG changes persisted for over next 10 minutes. So we were sweating as to a normal person wanting to do a treadmill and showing such gross ST changes and strong positivity on treadmill. Manish, can we switch to the presentation? So we talked to her. I think she was very reluctant. So stress test was her own offer, like you do my stress test. But when we said we'll do an angio, she was saying, no, I don't want an angio. But anyway, that's the usual story for many of us. And
sir, still the slides are not yet shared, sir.
Manish, the slides are not shared. Yeah, are you able to see the slides?
No, sir. I think we can see Vandana also join. Is she sharing slides?
No, Manish is sharing the slide.
Manish is, we can't see any Manish joins, sir. I will just check with Vandana.
Manish, where are the slides?
Now we can see, sir. Now.
All right, let's go. Now I will. So this is the story, as I mentioned, written on the top, strong positive stress test inside 1 minute. So I'm going to finish the right coronary first because, see, this is the right and the proximal portion was showing a very tight lesion. And there isn't much in the right coronary, except for the fact that her creatinine was 1.3 and we wanted to use minimum contrast. So since JR was not fitting very well, we switched to Amplas. So this is AL1, which is actually looking to the RCA origin. And this is an injection with the AL catheter. Also, just to reduce the contrast load, we chose a Fielder XT, which generally would make a very good advance since it's a hydrophilic wire. And you can see the Fielder XT, though the guide catheter sitting was not very coaxial, is making a decent progress all the way down. And then we brought in this NC balloon. So this, we do it many times when creatinine is high. Instead of putting a regular balloon and then the NC balloon, we take the NC balloon at the first go itself. So this is a 2.515 go high. Then there are good flows, no significant dissection, so to say. Stent in position starting from the ostium of RCA. And then the stent is deployed. And you can see the stent is taking a little time to get fully expanded. The good thing is, so many times we connect with this calcium and make sure that the calcium and the stent are sort of aligned, making sure that the stent is actually protruding, say, 1 millimeter into the aorta. So the ostium has to be covered when you're dealing with a proximal RCA lesion. Also, when we are positioning the stent, we also go to a caudal projection, and that allows you to give you a more precise position. And this is our final picture. The wire is still in. We generally, whenever you're using Amplas, we probably accept wire when we are taking pictures. Because if you take out the wire, catheter moves away from this position. When you are trying to re-engage, the protruding portion of the back end of the stent can get damaged sometimes. So I think this kind of picture is quite good. Turns out to be a very big right coronary artery, and you can see the 4 important distal branches of this right coronary artery. So this is how we started, tight lesion in the proximal one. This was, as I told you, 69-year-old diabetes for 10 years. So we had to sort of make sure that the stent expands. And you can actually see how much is the stent expansion possible. You can see, you'd probably feel it's a 3.0. And finally, we had taken a 3.5 NC balloon to something like 25, 26 atmosphere. So the proximal portion is really, really big and matches with the distality. The main importance is in the left system. Now, what we see here is a long left main, almost 60 millimeters long left main. And whenever we have such a long left main, one has to be ready that you may have to try different thinking and different techniques to handle this, because your guide catheter is not going to go in too much. If you push it in too much over the balloon, let's say, even then it would carry a risk of maybe an ostial dissection. So we accepted these pictures with the guide catheter and started working. And then we have to make a choice. See this view. This is a shallow areocranial or epicranial. And you can see it shows all the lesions very well. Now we have to worry about the creatinine. It's 1.3, and this is only a 40-kilo lady. So in long term, like in this particular procedure, we have to make sure that the contrast is minimum. Most of the time, this area, circumflex territory, ostial circumflex, we do it in areocaudal, but we thought to save the amount of contrast, we will stick to minimum views. And this is the final view, which shows circumflex on the top. The OM1, which is a big branch, is the next branch. This is the proximal diagonal. This is the LAD, which is showing a lesion in the mid portion. And overall, distality of the left main is also showing some disease, some narrowing. So the plan is to cover left main to LAD, then a stent at the diagonal origin, a stent at the circumflex origin, and then a stent towards the circumflex. So this was the plan. The guide catheter we chose was 7 EBU. Generally, I like to use 7. Many people like to do it with 6, especially if they want to keep the contrast load down, since creatinine is 1.3 and weight is only 40 kilo. You have so many bifurcations, like you have a bifurcation between circumflex and the OM1. You have a bifurcation between circumflex origin and the left main. You have a bifurcation between diagonal and the proximal LAD. So there are multiple bifurcations, and I thought we would be more comfortable with 7 French. So don't shy away from using a bigger diameter guide catheter. Also, the choice of wire. Now, here we have to wire probably so many vessels again and again. So we took Fielder XT as our first wire. The first wire, we wanted to go to the circumflex, but the lesion here was very tight. So we got the wire towards OM, which was easy to wire. Now, you might wonder why I'm doing everything in epicranial. This is exclusively to keep the contrast load down and not keep changing the angles again and again. So you can see the circumflex is subtotal or 99%. And so we got a microcatheter, and with microcatheter, you could direct the same wire towards the circumflex. Now, you might wonder whether it was really necessary to take filter XT, but this is a very slippery wire. You can sort of make a bend, advance it, and this is how we were able to keep the contrast down. So this and this is the wire going into OM1, and this is where it is now shaped towards these two are shaped towards the circumflex. You can see circumflex here, and the OM1 is coming just next to that. Well, the next was the wiring of the LED. We took hypercoat. Now, choice of wire, again, very important when you're dealing with a high creatinine, because if you can do wiring like this without contrast, it's going to be a great help to save nephropathy, contrast nephropathy for this patient. So the LED is wired with a hypercoat wire, and then we are trying to wire the OM1. So this is another hypercoat through the OM1. Now you might wonder why hypercoat. It's a slippery wire, sort of. Once it makes an entry, it doesn't take any time for the wire to go into the distality. You can see this wire here going the wrong way, but you pull it back and you could easily advance it into the correct OM1 branch. So all three wires are in good position in the good vessels, which we want to dilate first. So the balloon is now passed onto the LED wire. The distal or mid LED, mid to distal LED stent was placed. A stent was in position. We are trying to make sure that this stent is away from the origin of the diagonal one, because we do not want overlap of the stent just where the side branches originate. Once this position is happy, we deploy this stent. The stent is deployed. Most of the time, what I would do is just use about 6 atmospheric pressure, pull the balloon back, and with the same balloon go on high pressure. This would avoid pressure on the intima of the vessel beyond the stent. You would not have dissection at the distal end. So every time your back end is going to get stented, I always withdraw it by 1 or 2 millimeters, go high on pressure, and then take out the stent balloon. So we have these 3 wires, one stent in the mid and distal LED, and then we were wanting to post-dilate this. However, for some reason, I think the 3 wires were not allowing the balloon to go through. We could take a very small balloon, 1 millimeter balloon, just to sort of separate the wires, but anything beyond 1 was not going. So finally, we said we will take care of this LED a little bit later and concentrate on the native circumflex and OM1 bifurcation. Now, whenever you are dealing with bifurcation, like in this case, you have one bifurcation here between circumflex and OM1, another bifurcation between LED and diagonal origin, another bifurcation between left main distality and LED with origin of circumflex. So whenever you have 3 such important bifurcation and a critical multivessel disease and you want to play it safe, my choice of technique is always side branch stent first, then the main branch, and then the KISS. This is what we are planning to do in this case also. the first stent deployed is beyond the sort of multiple bifurcations at this side. So stent starts here and goes distally. So it's not going to come in way of any of these bifurcations. Also, you need to make a choice of stent which is going to get in easily. So we had this microcatheter and the balloon guiding. You can see the guide catheter and the microcatheter. And the microcatheter is actually sort of looking up into the circumflex. Once it is looking up, it will take all your balloons in. You realize here that there is no wire in the LAD because I think 3 wires were getting entangled again and again. So these kind of steps are not conventional and not that we recommend. But if you are forced to, make sure that the deployed stent in LAD is good, no dissection, and you can withdraw the wire. I'm not recommending, but if you are forced to, you can do that. So you have a microcatheter looking up towards the circumflex, balloon dilatation aggressively. Now this, when we say aggression, we go high pressure with a small diameter balloon. Like if this vessel is going to be 275 or 30, I would probably take 225 NC and go very high because the bed preparation also has to be very good. So we are making the microcatheter look into the circumflex, which is a very acute vein. And I didn't want to risk stent not going once we have dilated. So the stent position, the microcatheter tip position is already looking towards the vessel. And then we bring in a stent, and the stent is now positioned here. So whenever we are dealing with a mini crush technique, we have the side branch stent in position, and the main branch stent is going towards the OM1, circumflex to OM1. However, for whatever reasons, though we had prepared the bed very aggressively, this stent could not go beyond this point. And we kept feeling that this is not prepared, so we did multiple repeat high pressure inflation. But we really struggled on that stent position. So we finally removed that stent. You can see here, we have only one stent going towards circumflex from the origin of the OM branch. And this stent is inflated. We remove the balloon, and you can see here the stent position looks pretty good, just at the after the origin of the OM1 branch. And this is very important because you need to bring in another stent from circumflex to OM branch. So once we have deployed that, the guide catheter is brought in a bit. You remove the wire. You have the wire in the OM1 and see the stent. It's very easily slips into the position. So I think the wires were getting entangled. 3 of them first, we removed the LAD. Then after the circumflex stent was deployed, we removed the circumflex wire and the stent comes in very easily. So you have enough time and to make a good position. There are some things which I generally wouldn't like to do, like when we are putting a side branch stent in relation to the left main LAD, we have no wire in the LAD, which is generally not the case, which many of us would like to do. But we were struggling on sort of bends in these vessels. And that's why when we are taking this stent to the OM1, there's only one wire and on which the stent slips is. So once the stent is in position, you make sure that you're covering the ostium and you deploy the stent. use the same technique. Pull the balloon back 1 or 2 millimeters, go high on pressure like you can see here. The balloon is pulled back so that you don't get dissection distally and you get a good inflation. Here you can see the balloon is pulled back. So this stent is in LAD, number 1. Number 2 stent is in circumflex. Number 3 is origin of the circumflex towards OM1. So this is the 3 stent position that you can see. And we look reasonably happy, reasonably satisfied that all the work is going well. We have good flows, stent expansion. So now the time to wire the high diagonal. See, you have a wire in the OM1. That wire is removed from here and it is placed in the high diagonal. Now, this is where the importance of taking hydrophilic wire. I mean, you can save on contrast by using hydrophilic wires. There is a wire going down the LAD too, you can see here. And so you are now at the next bifurcation. So balloon towards D1, then followed by stent towards D1. So stent is reasonably in position on a D1 ostium. And at the same time, you have a stent starting from left main to join the deployed stent in the LAD. So this is obviously a big diameter stent. Your distal end is protected. So this is a 4O, and we will probably be dilating the back end with a 5O balloon. Stent boost was used extensively in this case, again and again. We know that we get radiation in big quantity when we do a stent boost, but we wanted to save on contrast because of high creatinine. And this is what the final position. Once we are happy on stent boost, the diagonal stent is deployed. One must also remember that we must have enough length proximal to this. So this stent position, this stent portion is going to get aggressively dilated with pot. So this 4O balloon, a 4O stent would be dilated with a 5O balloon to do a pot which allows good access to the side branch and also good stent and vessel wall opposition. So this stent, as you can see, deployed in diagonal at 6 atmosphere, pull the balloon back, as you can see here, and then go high pressure. Now, this is again and again, I'm telling you, in case if you are unable to address the side branch. Sometimes the balloon doesn't enter the side branch and you can't do a kiss. So this stent has to be aggressively dilated with the stent balloon itself before you come out. And you can see after deploying this stent in diagonal, you can see a nice flow. So you have good flow from circumflex to OM1, one stent, then circumflex native going up. The third is in diagonal. The first stent was placed in the mid-LAD, it had no side branches. And this stent is ready from left main to the previously put LAD stent. So once you have this kind of scenario, you're quite confident that everything is going well. And this last stent, fifth stent, is deployed in left main to LAD. And this is the scene. So we take multiple stent boost to make sure how the stents are looking in connection with each other. Now, mind you, we have put 5 stents, but not a single time we have tried kissing. This is because we have sort of multiple branches, multiple angles, and that's why chose the strategy where sideband stent is placed. And this is the final part. I think I give a lot of importance to this part. And that's why we kept enough length of stent left main, proximal bifurcation, trifurcation, etc. So that you can dilate extensively with the pot. Pot allows access to the side branches very well. And this is how it is. So once the pot is done, you can address this diagonal side branch with a wire. The distal part of LED is dilated aggressively with 3.5 balloon. And then 1 millimeter balloon is used to stretch the stent, and we can get a bigger balloon towards diagonal. So this is the first case between diagonal and the LED stent. Once that is done, the diagonal is a happy vessel. We put the wire into the OM1. The balloon is on the LED wire, and then we bring another balloon. These are all NC balloons, and you try and get maximum diameter. You can sort of choose balloon pressures, like this is 3.5 on LED and 3.0 on diagonal. So when you go up to 6 and then stay at 6 on LED, finish diagonal. So diagonal, you go to maybe 25, 30, come back to 6, go high on LED, maybe 25, 30. And then as you are coming down, push up the diagonal pressures. So both ultimately would be at 12 or 15 atmospheric pressure together. And use stent books again and again. You can see we are using stent books to tell us whether the vessels are looking good. Never forget a repot. Now this final pot is very important, and that is why we kept enough length of the stent proximal to all these bifurcation, so that this final pot balloon doesn't hurt the bifurcation. So though this looks good, a final pot, I think, is an absolute necessity. And then we check this picture in areocaudal. And in areocaudal, you can see the long left main, the stent towards circumflex, stent towards OM1, or diagonal, and LED. So we started like this, and we have 5 stents placed, and the situation lies like this. So compare this in the beginning and compare this in the end. We have 2 stents in LED and LED to left main, 1 stent going from circumflex mouth towards OM1, another one going from here towards native circumflex, and another from a diagonal origin towards diagonal. So we did a kiss here. We did a kiss here on circumflex LED, but we did not do a kiss on circumflex and OM. I think it was about 3.5 hours, and we didn't want to put too much contrast in her. And we thought overall the lesions are well dilated. So this was the only spot where we did not do a kiss. But you can see the vessels in epicranial looks very, very good in areocaudal, where you could hardly see any circumflex OM circulation. You can see nice circulation here. And thus, the patient has 5 + 2, 7 stents. But we are very happy. It's more than a month. She's very active. I am actually surprised that this was a lady coming from a nearby village. Why she should ask for a treadmill herself? I mean, it's okay. We were doing her husband's treadmill, and he had 3-year-old angioplasty. But she wanted, so obviously my feeling is she did not narrate the complaints, but she was probably feeling that she has some problem. And she's the one who made the diagnosis, I would feel. She's the one who wanted a treadmill, and this is how a very difficult RCA as well as left main trifurcation or quadrification lesion, which needed 5 + 2 stents, Good. One might say why you did not image. Yes, we could have imaged, but it's already like surgical time. It's about 3.5 hour procedure time, including angio discussion with the family and the angioplasty. So we were quite happy with this kind of. But yes, if we had more time, most of the time in my lab, other people's are breathing down your neck. That you have angioplasty, they would keep about 1.5 hours. This went on for 3.5 hours. So I think we have to release the cats. So we started from right, and we ended on the left with 5 + 2, 5 + 1, 6 stents in this particular case. I'm sorry I took a lot of time, Dr. Onkar, but I think the case deserves so much time. Dr. Srinivas, any comments, or Abdul?
Oh, great case, sir. It needs a lot of passion to do such cases. Many people won't bother to put in so much efforts, and many people would send the patients for surgery directly. But it needs a lot of passion to do such work, and you have effectively shown how to do it correctly. And only thing what I thought is probably if RCA was done, creatinine was high, we could have staged it for next day or gave something unless patient was totally unstable. But the lesions in RCA looked very critical. LAD also, this left side also was tight, but probably we can stage, I think, if possible. But I don't know what was the patient's condition and pain, other things. But you used Poorman's IVUS as this stent boost as a Poorman's IVUS. It was very effectively seen how the stents were being positioned. Yes. That stent boost.
Actually, I'm sorry, I could not get the images of stent boost, but every time I said stent boost, the stent boost really helped us to make metal-metal contact very strong and convenient.
But many of the people won't take so much of stress and work for 3 hours in the lab, sir. That is what bothers me. But suppose you did total revascularization again. What is also important is not just to do one branch, and this is only for listeners I'm saying. Just do one stent and come out. If you are planning to do, then do the total revascularization like what sir has shown. I think that's a way. And with the latest best quality stents, I feel we can offer such therapy to patients because we don't see that restenosis very commonly like before. And if the initial result is quite good and patients do well on follow-up, I think that's a great demonstration.
Dr. Srinivas, these were all Onyx. And the important thing about Onyx is the 4.0 stent in the proximal LAD can be stretched very easily with a 5.0 balloon or 5.5 balloon. And the stent maintains its sort of nature or perfection and continues to do a good job. So whenever I have difficult side branches, like in this case, would you have chosen any other technique? Like in all the individual bifurcations, we did one circumflex OM1, then we did circumflex left main, then we did circumflex LAD diagonal. These were 3 bifurcations we are dealing with. And to keep the procedure quick and simple, I think something like DK crush should be avoided in this case. There may be somebody who would still insist on DK crush, but DK crush has a couple of extra steps. And in every bifurcation, if we have to take those extra steps, I think you'd probably waste another 20 minutes extra. And more importantly, more contrast, which we couldn't afford in this case.
How much contrast was used here, sir?
We used about 180 plus about 30 on the right. We were very particular that we will not waste contrast on the right because we needed more contrast on the left. All right, Dr. Srinivas, are there any other comments?
Great demonstration, sir. I think your planning also is very important. Where to which position, which stent to be done first, and all that is important because you
In
put a
fact,
proper stent.
Dr. Srinivas, I would feel, see, the entire problem is that the distality of the left main.
Yeah.
The diagonal is like a ramus.
Yeah.
And I have probably never done a location distality of the left main in this kind of view. So most of us would probably switch to spider or something like that.
The final result came out quite well, sir. It's looking excellent.
Yeah, I think we were very lucky that we got a nice angle.
Yeah.
And luckily, we had to, of course, we joined the angio with angioplasty for insurance reason. But I think we are able to manage her without any renal issue post-procedure. All right, Dr. Onkar, we go to next.
I think, sir, other faculty, Dr. Prashant Advani is not able to, he's joined, but somehow he's facing some problems. So we may stop here at this point of time. We had 2 cases.
So we have one more presentation or no?
No, sir, not possible, sir, because that's what Prashant Advani suggested us, sir.
Okay. So no more
But
presentation.
yes, sir's case was worth 3-4 cases anyway. The right one.
After this case, there is no presentation. People will require some time to digest this
Dr.
case.
Srinivas, let us discuss this particular case. I will just show you the left picture. And this is a still. And this is a movie, if I can get it running.
I'm able to see it, sir.
Yeah. So, does any other procedure come to your mind to deal with this kind of case? I was very worried. I'm generally worried about the side branches. Like if you put a main branch stent, and then if you have trouble on the side branches, and if you waste time, the patient gets ischemic, starts shouting with angina. In that setting, to address the side branch is very difficult. So majority of the time, I'm not using mini crush as my preferred technique in this particular case. Side branch circumflex, number 1. Side branch circumflex origin, number 2. Side branch diagonal origin, number 3. And then main branch, and then the final kiss. I think the way we did, I thought the side branches were well preserved, well flowing, and then to push it from, say, 98, 97% to 100%, we use the final kiss. So even if we had missed the final kiss, like we did not do a final kiss on this branch, I think it's reasonable.
Yes, sir. I think data also, unless there is left main bifurcation, many of the trials show that kiss or no kiss. Sometimes it may not be too much different unless there's definite under expansion or something which is obviously seen. And the other thing which you told about Onyx is because the side branch access and other things are quite better. Radio opacity is also slightly better. I think that's how it worked well. But many people would have sent this for surgery because left main trifurcation type of thing, and RCA also ostium, and then it goes into very high syntax score, and people won't dare to do PCI unless the patient requests us. If patient is requesting us to avoid surgery and do procedure, then probably we would do. But otherwise, surgical option was given to her, sir. You didn't give it up.
No, we did not, because she came on her own. And as I told you, she came with her husband, and she wanted a treadmill herself. So I was very surprised why a relation of a patient is asking for a treadmill. That too, a 70-year-old from a small village town. And I was very surprised, but then my technician convinced her that yes, we can do it. And luckily for her and luckily for us, we were able to find such an advanced disease in her.
Yeah, it's sometimes God's It's her fortune that she had some intuition. I think she must be having some discomfort, which she was not expressing properly. Many times it happens, and lucky that she was landed up with you. She had such a good result. Otherwise, it could be other way sometimes.
No, but I think it was a very good case for surgeon too.
Yes.
Like all these branches, the OM1, diagonal, LAD, and you saw the right. Huh?
The targets are quite good, you're saying. That
Very good
right,
targets. No?
Yes.
So
the only time where we give surgical option in today's era, definitely, sir, is something like left main trifurcation along with osteal RCA, or a total occlusion of RCA along with left main, something like that. But even here, you showed it effectively that PCI can be offered. This catheter, the such sort of thing, sir, nowadays we are using this XB3 RCA, which is another type of catheter, that also engages quite well. We are worried sometimes to use Amplatzer because of osteal disease. But XB3 RCA...
In fact, even for right, we use the AL1.
Yes, yes.
AL1 actually makes a good connect with the RCA origin.
Yes, yes. But
I don't know what is your experience with AL1.
No, it's good, sir. We use AL1 only if there is support issue, but sometimes the osteal disease, if you are worried to take Amplatzer catheter because it might dissect, this XB3 RCA is another new catheter which came, which actually is quite good, almost like Amplatzer, but without much of problems of engaging like it with Amplatzer. The XB3 RCA.
No, I have personally no experience with XB3.
Yeah. Great case, sir. Thank you, sir.
Okay, Onkar, what is the plan for next meeting?
Sir, we will be having next program on 24th, sir. Today we may stop at this point of time because we have no further case today, sir.
What happened to Dr. Kuti? We missed him last time also, I think.
Yes, sir, we missed him. So must be, sir, busy because Dr. Prashant Advani also is busy because there is a emergency and he has to rush into that. He has joined, I think, but there was a...
I'm worried about Dr. Abdul.
Hi, Mr. Good evening.
Where are you?
Just joined it.
Sir, as a chemo of my father going on, I just got stuck up. I'm very, very sorry. I missed out the pulse of wisdom for you, Dr. Srinivas, sir. Just peeping, I thought I was wondering that it got finished up. And one more case?
Just finished.
Oh, no. We are through. You have a case or you have a presentation?
I could say one case, but I didn't prepare it much. I thought that I have to moderate, and I got stuck up terribly, very terribly. I'm sorry, Omkar. Sir.
No. I hope everything goes well with family. That's very important. All our good wishes.
Thank you, sir.
So maybe, sir, our next program is on 24th. You can present the case on 24th and moderate. That can also be possible, sir, 24th, if you can.
You're asking me, Onkar?
Yeah, maybe we can connect after this meeting, sir, for 24th
sure.
program.
But align it with Hiramas, sir, as his time slot and availability is very busy. Yeah. Your case also, Dr. Srinivas.
Yeah. Thank you. Affiliate, we started doing the zero contrast to low contrast PCA. We're collecting data, sir. Whenever you want us to show, I can show some cases where we are limiting contrast and nowadays I'm worried to do it.
If it is a zero contrast angioplasty, I want to see it next meeting.
So zero, mostly zero, but only last final check shots. Just for sake of documentation, we take with few CC. That's all.
Dr. Onkar, keep time for Dr. Srinivas Kumar.
Yes, sir. Definitely, sir. Definitely.
Whenever sir wants, I'll show that. No problem.
Specifically for zero contrast. No, this is a new, something new, and I think we should progress in that direction.
Yes, sir. Nowadays, I'm not worried about creatinine anymore, sir, honestly.
Sure, sir. I just take an opportunity as you are around here.
Contrast levels are less than 1 ml per kg. Nothing happens generally, sir. 20-30 ml contrast is not creating too much trouble.
20-30 is a diagnostic angio amount.
No, PTCI I'm saying. PCI.
I think it's very difficult to do unless it's a simple type A lesion to do
Yeah,
it.
CTOs and very complex bifurcations like this, it may not be possible, sir. But we have done left main, we have done triple vessel stentings, but straightforward ones, not such a complex one.
Sir, for all kinds of this, excuse me, sir, would you, there's an antithrombotic strategy afterwards for the rest of the life for intensive secondary prevention. Likewise, your case, whatever little I had that, stress is coming very strongly positive or the patient denying or that is a complex. Do you think we embracing the twilight strategy in India, say, even with these type of complex procedures, only TICA alone after 3 months of standards? Or would you like to go ahead with the conventional one?
And then there was a Korean study called TICO. Both indicated that aspirin can be stopped and only ticagrelor can be continued. To me, right from beginning, I was never a big believer of aspirin. And aspirin you give or don't give doesn't make too much difference according to me. But that's my personal opinion.
So you started embracing this practice, or you do it? So we follow you, like you being an Indian legend in Indian setting.
Give it, but if there is a contraindication for usage of aspirin, like known peptic ulcer, recent bleed, then we skip aspirin. Maybe we might give it for first 1 month.
So for the case you finish with, sir, after 1 year, what would you do? Like
nothing, just Brilinta and. That's
60 or Ticapalt 60 or something? Or,
no. 60 is always beyond 1 year. Dr. Srinivas, are you there?
Year, yes.
Yeah. Please come to my help because this 60 business is, I don't think in India we follow too much because of non-availability of 60 milligram.
No. What he's asking is after 1 year only, sir. Not
after 1 year only, sir.
Okay. Dr. Onkar, you have with Emcure 60 milligram?
Yes, sir. Ticapalt 60 milligram.
Yes. So
many of the times, as Prashant, as Dr. Srinath sir said, we are stopping aspirin early, nothing happens. Actually, we are stopping after a week now with HBR patients. And actually, Ramesh and others in US are telling they are giving only for 1 day on the day of procedure. Still nothing is happening. So we have because stronger antiplatelet effect of ticagrelor. I think even if you are not giving aspirin, still patients are doing all right.
And like the other one, this guy
has background. I had a lady, and I sometimes show that case. We got her in hospital at about 11 with about 40 minutes of chest pain, anterior MI, and a very simple lesion in the anterior LAD territory just after the origin. So we put a stent, something like 415, and she was on Brilinta and aspirin, and she thrombosed, say, about 8 or 10 hours later. The imaging of the stent, I mean, we couldn't find any fault. It was a 4/15 length stent in the proximal LAD, not even ostial. But yes, we learned that ticagrelor also can have something like clopidogrel resistance. And luckily, it hasn't happened again to any one of us.
Sometimes it also happens, recently, it happens in some of those important VIP syndromes type patients. We took a patient for primary and a lot of hype, everybody was around, and then probably we thought, I checked it personally with my fellow and junior cardiologist also whether ticagrelor was given. They said it's given. We put a stent. Then immediately after coming out, he was all right, flow improved, pain decreased. The ICU shifted, then I changed, and then at night time it changed, and we saw again ECG was showing some sort of ST elevations. Then I had some doubt. Then we again took the back, and then the thrombus, it immediately, actually, half an hour time, that's all. And then that's how, if the ticagrelor is not given properly, then stents could immediately thrombose. And some.
What do you mean not given properly? I mean, just.
So ticagrelor, in that all this garbage of VIPs and all that stuff, so many things. Somebody said they didn't give.
Not given. You're talking of not given.
So it missed it. So it was a practical learning for me that it was not given stent half an hour thrombus. Within half an hour of shifting, then we didn't even go from hospital. Luckily, immediately we shifted back, and we didn't highlight it so much. But immediately again, crushed one was given, and then the patient did well afterwards. So it documents that it is really, really very important to give this drug optimally, and such sort of complex cases we can do only because of a high quality antiplatelet effect of ticagrelor.
No, my only case where ticagrelor had a total occlusion was a procedure done at about 12 in the afternoon. Brilinta was given, and at about 9 in the evening, so 9 hours later, patient had an occlusion with fresh changes. So in my case, it was clearly given, and that is my only experience of ticagrelor given. Like we have so many cases, not so many, but at least we have a dozen cases each where Plavix is given and patient still has a stent thrombus.
We had one patient of graft angioplasty, graft occlusion after ticagrelor in COVID times. Patient was having COVID, just recovered from COVID. We don't know how much was it because of that. We hardly saw stent thrombosis, especially the later generation ticagrelor and other things. One stent thrombosis I saw. This was a mistake. Otherwise, properly given, only one graft angioplasty we saw stent thrombosis in the COVID time, the ticagrelor.
And Shri sir, like, what about dual pathway inhibition for the kind of patient that you finish, or that the lady reports a TIA or something, and after 1 year would like to shift to, instead of say ticagrelor, clopidogrel, a kind of a milder P2Y12, Exafib or rivaroxaban like this in this patient, instead of aspirin in the trial. The Compass used aspirin, but clopidogrel instead.
Dr. Srinivas, you got the question.
Whatever you do is after 1 year, not
after 1 year, sir. As a dual pathway inhibition, as a strategy, like we use Compass strategy in polyvascular bed afflicted patients, sir. So the patient that you finish a complex angioplasty, a complex ASCVD, but has a vascular, other say a carotid vascular or some prior stroke or some PAD existent after 1 year. Would you like to remove ticagrelor and put rather rivaroxaban 2.5 with clopidogrel rather than aspirin?
The same question we asked Ticapalt, who was the speaker, the original was, he was the principal investigator for that also. So the answer he gave looked very interesting to me. We also have a feeling like that. I asked the same question to him. Why did you do with the clopidogrel and only this low dose rivaroxaban? What he said, the commonest practice, what was going on then was just giving aspirin long term. So that's how we planned the usage of a small dose ricosprin with aspirin only, because anyway you are not using clopidogrel after many there. No, it's a big issue there. Many people stop aspirin after 1 year in US, whereas in India we tend to continue. In fact, we stop aspirin and give clopidogrel, whereas in US nobody does that. He was telling most of the people will only.
But then in US, Dr. Srinivas, they are shifting for prolonged time. They think there's a residual thrombotic risk, which like in 1 year is a very arbitrary thing. And the residual risk, don't stop. So
but if you're giving ricosprin again, rivaroxaban, again, don't give very high thing antiplatelet. We never know. As of now, the data is there only with aspirin.
Yeah, so that's why I asked you, an off-label thing, or you like a clopidogrel with clopidogrel. So they use aspirin 100 mg, and we use mostly 75 mg. So use clopidogrel instead and mix up for kind of 100 mg aspirin and bit more antiplatelet action, which corroborates well with say Exafib 2.5.
No, I wouldn't make any difference between 75 aspirin, 81 aspirin, or 100 milligram aspirin. I think it's still a low dose aspirin. In fact, some people would also feel that 150 is the low dose aspirin.
Yeah.
So I think they're all effective wise. I think same efficacy. Nobody can prove or disprove. But when I talk of small dose, like once the ticagrelor and prasugrel are available, most of the time aspirin dosage, definitely with ticagrelor, it's only 75.
75.
Yeah. For prasugrel, we still give a full dose.
But Dr. Srinivas, have you ever used clopidogrel with rivaroxaban for any of your patient, polyvascular build patient, ever, off-label?
No, once we are worried always about the bleeding aspects. Even if they are planning us to do the study, but still there also we don't put them too often because this bleeding thing always bothers us. So whenever we are giving either ticagrelor or clopidogrel, somehow we are not comfortable giving this again dual pathway or whatever you call with rivaroxaban. So when you are using rivaroxaban, definitely we are giving only aspirin as of now because data also came like that. And your point is taken. That's what bothered me. I asked with them. We could study in Indian subcontinent where such high risk and low bleeding risk patients, high thrombotic burden, like young people which suffer polyvascular disease, stroke, such patients where there is no problem of bleeding, not worry of bleeding, you could try with clopidogrel and low dose rivaroxaban. We need to create such data. As of now, we are not doing. I think, sir, it's time. Oh, okay, Onkar, you can over to you.
Yes, sir. We can stop here. Sir, can we stop here for call for a day?
Yeah.
Okay. So thank you very much, sir, presenting very interesting case. I thanks our course director, Dr. M.S. Hiremat, sir. I also thank our moderator, Dr. Srinivas Kumar, sir, bringing a lot of discussion. I also thank Dr. Prashant Advani and our speaker for the day. With this note, we will be catching up again on 24th of this month with 2 more interesting cases and a lot of discussion. Till then, good night and have a nice time ahead. Thank you very much.
Thank you.
Thank you.
Thank you very much, sir. God bless. Good night. Bye, James.
Bye.
Recording stopped.